Welcome. I'm Derek O'Keefe. I will be hosting and moderating tonight's session. This is the webinar on the future of public health in the context of the worldwide pandemic. We are coming up on, the grim sort of one-year anniversary of the real beginnings of serious public health measures and the apprehension in the world outside of Iran, China, that this was indeed a pandemic. That would be serious measures taken. So, obviously this is as good a time as any to be reflecting on the lessons from the past year. And we thank you all for joining us. We have some great panelists tonight. This is the second in a series of panel discussions hosted by the Institute for Humanities at SFU, featuring leading activists and thinkers addressing the short and long emergencies facing our society, including, of course, most obviously this pandemic, and how these crises have exacerbated or exposed previously existing injustices. So at our first session, we addressed the climate emergency and proposals for a just recovery. Tonight, we're talking about the inadequacies of existing public healthcare infrastructure. We'll be talking about surveillance, tech, and policing, as well as how an economic recovery can be structured so as to reduce inequality. And in the final session later in the spring, we will be bringing together leading figures from movements for systemic change to discuss the lessons of the pandemic for all those interested in fighting for a better world going forward. And of course, sort of underlying the analysis and the work that's done at the Institute and, by progressive thinkers and activists in this part of the world, we know that an underlying cause of these injustices is colonialism and all the interlinked injustices stemming from that past and present reality. So we not only acknowledge at these sessions that our work is done on the territory of the Squamish, Tsleil-Waututh, and Musqueam nations, the territory that was stolen from them, but we actively work towards any effort that can aim towards returning the land and sovereignty to the Indigenous peoples. So we want to do more than just the acknowledgement, is my way of saying. And the Institute's director, Samir Gandesha, hosted the first session, moderated the first session. He's asked me to fill in tonight. So if you don't know me, I'm an editor with Ricochet Media, a longtime activist and editor and producer of independent media here in Vancouver. We have three really qualified speakers coming at this question from different angles. So I'll just introduce them first, and then we will have speaker presentations of around 10 minutes each. And then we'll have the rest of the session. We aim to put it off at 90 minutes because we know everyone's living a lot of their lives in these Zoom calls. So we're going to keep it at 90 minutes. But the last 45 minutes or so will be to take your questions. And our friend Susan in the chat is pointing out that today's session comes just a few hours after the Liberal federal government has voted against a motion to implement universal pharmacare, a motion tabled by the NDP. So there were political reasons for shutting this down, but I'm in my 40s now, but for my entire adult life, the federal Liberals have been talking about someday bringing in pharmacare, someday bringing in childcare. So anyway, thank you, Susan, for pointing that out. Tonight's discussion comes on the heels of that latest disappointing vote. And actually, our first speaker is an expert in pharmaceutical policy generally. Colleen Fuller is with us. She is the president of the Reach Community Health Center on Commercial Drive and a researcher and writer focused on health and pharmaceutical policy. She's a co-founder of Independent Voices for Safe and Effective Drugs, which over the last 5 years has worked for fair drug prices, national Pharmacare, and stronger regulations governing drug and vaccine manufacturers. She's also on the steering committee of BC Therapeutics Initiative. And Colleen is going to talk about what the pandemic has shown us about Canada's capacity or lack of capacity to roll out vaccines, among other things. And then we'll have a presentation by Ishmam Bhuiyan, who is a UBC student organizer, a veteran organizer now, well beyond his years. So I met Ishmam when he was a high school student advocating for the MARPOL modular housing project. And Ishmam played a really key role advocating for housing justice and the right to the city for people to be housed in South Vancouver. And that helped open the way to a lot more modular housing around the city. And then last year, I guess last spring or last March, Ishmam was one of the founders of the COVID Coming Together Vancouver initiative, which is now a Facebook group with well over 30,000 members. But beyond just a social media presence, that mutual aid effort has delivered a lot of concrete aid to hundreds, if not thousands, of people in Vancouver during this pandemic. So Ishmam's going to talk to us about that initiative and what it sort of says about the gaps that need to be filled in our public health system. And then our final speaker is Stephane Bilodeau, an engineer, a PhD, and a member of COVID Stop and endcoronavirus.org. COVID Stop is a civil society effort in Quebec primarily, aimed at stronger, advocating for stronger COVID reduction and elimination policies in Quebec specifically, but that's one province where I think it's the province with the highest death rate, highest number of deaths during this pandemic by quite a margin. So we're very interested to hear what Stephane has to say and some of the lessons that can be applied. And he'll be doing some comparisons to other jurisdictions worldwide that have been successful in curbing the pandemic or indeed eliminating COVID. So, and I should say we're 1 year into this, but obviously looking ahead, this is not going to be the last pandemic of the 21st century. And we want to learn the lessons, not just to build a better society, but to make sure that the next time this happens, or the next coronavirus, for example, is dealt with much better here in Canada and worldwide. So that's enough from me. Thank you all for joining us again. Thank you to the Institute for hosting and asking me to fill in and moderate tonight. And we will go right to Colleen Fuller.
Okay.
The floor is.
And hi, everybody. And thank you, Derek, for that acknowledgement that we are on unceded territories, which some of us remember all the time and some of us unfortunately never remember. But I wanted to, I'm actually going to focus on the issue of access to vaccines. That's one of the big issues that we're confronting right now. And what some of the, and why that is an issue of justice and equity, because that's what it is, access to the vaccines, to other therapeutic products are social justice issues. I'm also going to mainly focus on one step that I think that we need to take in order to create a basis of justice and equity in not just the distribution of the vaccine, that is obviously top of mind right now, but in the longer term, access to medicines generally, and that includes vaccines in Canada. We have in Canada, we have a very weak public policy basis for access, and that means that we have a weak policy system to protect supply and affordability. And that weak policy has put the global pharmaceutical industry in the driver's seat. The industry is not going to, because they don't want to, they're not going to contribute to creating an environment where access to medicines and vaccines are based on a system of justice and need. They are profit oriented, and they have their greed basically has really caused a lot of harm across the country, and both because of their actions and their inactions. The pharmaceutical industry is awful, and I'm always asking myself, why are they so awful? They're awful for lots of different reasons, but one of the key reasons is because our governments have enacted laws and regulations, They've signed trade deals that are designed specifically to uphold and protect the interests of the industry, which of course are to increase profits nonstop. During the last 35 years, in particular, Canada has abandoned nearly every single public policy tool that we had to keep drug costs low and minimize barriers to access to safe and effective drugs. At the international level, Canada has also played a really shameful role in efforts around the world to support access to COVID vaccines. For example, Canada voted twice against a proposal from South Africa and India to waive the patent on the COVID vaccine so that countries, particularly low and middle income countries, could manufacture their own vaccines rather than waiting around for pharma to get around to supplying it. But even worse than that, Canada dipped into the COVAX fund, which was set up to ensure that all people around the world would get access to the vaccine, regardless of where they live or whether they were rich or poor. So I'm going to talk about one of the things that we can do to make sure that we create a system of supply and access that are based on the principles of justice, equity, safety, and effectiveness, which are really important, and value for money. I'm going to focus on public manufacturing. There are two other aspects to this discussion that I won't be able to talk about this evening. One is national pharmacare, which of course went down the toilet in the House of Commons today, thanks to the Liberals and Conservatives and the Bloc. And the other is a system of price controls, a strong system of price controls. So access and supply are intertwined. If there's no supply, there's no access. It's as simple as that. There's been a lot of focus in the last month in particular about the fact that vaccines are, that the supply of vaccines to Canada have been delayed. The comparison that we normally see is between Canada and the US. The US has had no significant supply problem, and the number of vaccinations that have taken place in the US is relative to Canada certainly much, much higher. The problem is that the distribution of the vaccine in the United States is chaotic and totally inequitable. So populations that are most at risk of severe disease are, that's Indigenous, Black, and Brown communities, are receiving the vaccine at much lower rates than whites. Residents of long-term care, healthcare workers, other frontline workers, and so forth and so on, are so that what's going on in the US is kind of a microcosm of what's going on globally. And as I said, Canada has played a very poor role in that regard. But if we're going to compare Canada to anybody, it should not be the US. It's more appropriately the European Union. Canada and the EU have similar healthcare systems, and both the EU and Canada have confronted significant delays in the supply of the vaccine. But at around January 25th, until about January 25th, Canada and the EU had a vaccination rate that was very similar, and so they were pretty much on par with each other. But around the end of January, that began to change, and we saw a real uptick in the number of vaccines that were given in the European Union, but not in Canada. Canada still lags behind the EU. So what happened there? Well, there are three theories, basically. One is that the pharmaceutical industry doesn't feel welcome in Canada because we have price controls. We have very weak price controls, but nonetheless, the pharmaceutical industry is very, very aggressively opposed to price controls. And so the solution to make them feel more welcome is to eliminate price controls. And in fact, we should go even further than that, according to Vaughn Palmer at the Vancouver Sun. And we should extend patents even further than the current 20 years. And we should never, ever, ever think about waiving the patent so that Canadian manufacturers would be able to manufacture and supply the vaccine. So that theory is complete bunk, of course, and the real reason that that we are are lagging behind Europe at the moment, and this is as legitimate a theory as Von Palmer's, is because on January 21st, the European Union threatened to sue the industry if they didn't supply the vaccine. Canada, on the other hand, which is lagging far behind, delayed implementation of revised price control guidelines that would strengthen our ability to maintain fair prices in Canada. We struck a deal with the vaccine makers not to reveal any of the details of the agreements that they've made with between Canada and the vaccine makers. And we also have acknowledged publicly that we are at the mercy of the pharmaceutical industry when it comes to supplying the vaccine. And that's why we're getting screwed. It's not because we are accommodating we don't have the welcome mat out for the industry. It's because we're bending over backwards to give them whatever they want. So the second theory about why we're lagging behind is because we don't have a domestic manufacturing sector in vaccines. And so therefore we should inject public funds into biotech companies so that they can make the vaccine. But from my perspective, that's just another junk theory. The new research and development model that is adopted in Canada, embraced in Canada by the private sector is this, that you tap into public research dollars, you commercialize your discoveries, and you make billions of dollars selling those discoveries to the global pharmaceutical sector. And in fact, one commentator said last year that this is exactly how quote unquote savvy Canadian entrepreneurs from the current pharmaceutical profit from the current pharmaceutical landscape. This is not an equity and justice model. This is not going to get us where we need to go. The third theory, which is the one that I subscribe to, is that, first of all, domestic manufacturers are not different enough from the global pharmaceutical industry, and that what we really need is a public manufacturer. Public manufacture is absolutely key to ensuring that we can create a system that is more just and more equitable in regard to access to safe medicines and vaccines. And it's not actually just a theory, it's based on our own historical experience. As I'm sure a lot of you know, we used to have a public manufacturer called Connaught Labs. Connaught was set up in 1914 during a diphtheria outbreak in Canada. And the city of Toronto, which was relying on an American company to supply the vaccine, was basically told, if you want to pay through the nose for the vaccine, we'll supply it after we supply Americans. So the city went to the University of Toronto and asked them to develop a vaccine, which the university did. And they created this lab, Connaught Labs, that developed and distributed the vaccine to provinces across the country at cost. And they were then able to supply the vaccine for free to their own residents. 7 years later, in 1921, one of the most important discoveries in medical history took place at Connaught, and that was the discovery of insulin. Royalties on Connaught became a really significant insulin manufacturer for Canadians, but also internationally. The royalties on insulin were used to support the first infrastructure for medical and scientific research at Canadian universities. This was very important in the development of more vaccines and more medicines for Canadians and for the globe, basically. So that arrangement with Connaught, the fact that it was a public manufacturer, meant that it was able also to play one of the most significant roles in enabling provinces to establish provincial drug plans, public drug plans. These drug plans leave a lot to be desired. They don't go nearly far enough, but the fact that there was a public manufacturer is what enabled the provinces to move in that direction. Connaught also became a major international vaccine maker. It was instrumental in the development of the polio vaccine, the meningitis vaccine. It was instrumental in the eradication of smallpox in the mid-1970s. So over that period, we had a very rich experience in public manufacturing. But then came the 1980s and neoliberalism, and the idea of a public manufacturer fell into disrepute. The Mulroney government, which was elected in 1984, one of the first things that they did was to privatize Connaught because they said it no longer served a public purpose. I mean, unbelievably, that was the position that they took. So Connaught was a public manufacturer for about 70 years. It survived as a private domestic Canadian manufacturer for 5 years. And in 1989, it was acquired by what is now Sanofi, which is, not ironically, one of the biggest vaccine makers in the world. And we've just cut a deal with them to supply COVID vaccines to Canada. So a lot of people will say that was then and this is now. But I tell you that if we want a system of access to safe and effective drugs and vaccines, this is an issue that we are going to have a discussion about. And right now, the people who have an interest in a private biotech sector are manipulating this discussion and trying to get the whole discussion about a public manufacturer off the table. That is one of the keys, or one of the legs on this three-legged stool. The other two are national pharmacare and fair drug pricing. I'm going to end it there, and I look forward to the comments from my co-panelists. Thank you.
Thank you so much, Colleen. And I don't know if I mentioned off the top, but we will hold the questions till after the three panelists. And yeah, questions can be entered in the chat, but best to hold them for after Stephane's presentation. We turn now to Ishmam.
Thanks so much for having me. Can you hear me? Yeah.
I'm good.
Okay. I'm calling in from the unceded lands of the Musqueam, the Squamish, and the Tsleil-Waututh peoples. Thanks, Derek, for the invitation. It's a deep honor to be here to talk today. Changing tone a little bit, I'm here to talk about experiences as an organizer during the COVID-19 pandemic and crises and injustices in the healthcare system that have emerged through this work. I'm a student at UBC. I was involved in setting up COVID-19 Coming Together, which I'll talk about in a sec. But I think a little bit of context is required. Part of my work with COVID-19 Coming Together came from my role with the UBC Social Justice Center, which is a resource group that works towards transformative change, justice, and equity. And we organize around local causes mostly, while envisioning alternative futures based on what we view as resistance, reciprocity, and community. So along with other organizers and mostly volunteers now, who've kind of taken autonomous control over the group, I was involved in setting up this mutual aid network when the pandemic really began to escalate in BC in late March of 2020. And the reason we set this up is we immediately saw our communities being torn apart. We were all in physical isolation, and we realized that this would mean that vulnerable people and people who rely on vital services would lose access very quickly. So I got together with 5 other students, university students here at UBC, and 1 student at McGill to create COVID-19 Coming Together, which I think at one point had 35,000 people, and it took the form of a website, web app, and a Facebook group. And the platforms were used and are currently being used by people who need access to groceries, to medications, to household items. And many of these people are immunocompromised and or disabled and have lost their ability to access resources that would otherwise be available. And while building this community as people with a background mostly in political organizing, we recognize the need to, yes, create a strong set of community guidelines to maintain a respectful, inclusive, and welcoming environment, but also to make sure to always prioritize building a community that was coming together in solidarity, despite the physical barriers the pandemic was imposing on us. And I think my biggest takeaway from this experience as a lesson going forward is this incredible ability that our communities have to come together, to support each other, to share resources, especially in times of collective crisis. More concretely, though, as COVID-19 really has unfolded in our communities, the effects, the negative effects of the pandemic conspicuously have unevenly impacted migrants, racialized people, people with precarious work, poor people, housing insecure people, disabled people, and seniors. And so to us, mutual aid wasn't only an exercise in survival and connecting people, but equally so, it was a political endeavor. So guided by the work of folks like Dean Spade, we recognized our role as organizers during a global pandemic as one of showing solidarity and amplifying and directly plugging into social movements that have long been fighting for change that our communities need now more than ever. So we viewed it as imperative that in the middle of a health crisis, our governments are responsive to the needs of marginalized and working class people, and that our governments act in a way that ensured workers' rights, funding to public health initiatives, access to healthcare, childcare, proper funding to social supports, access to clean water, dignified housing, and a respect for Indigenous self-governance. And I think that COVID-19 uniquely showed an opportunity to come together and join forces while also building a more inclusive and equitable future for all of us, to really begin to envision a future in which all of us has access to healthcare, childcare, social supports, clean water, and the list goes on. And I think that it was a really opportune moment to be, to not only be a network of people who were depending on each other for material supports, but one that was deeply political. So one of the ways that we enacted this understanding was through creating and organizing around a set of demands on various political issues that were pertinent last summer and are still ongoing. So we called for an immediate stoppage of the work on the Coastal GasLink pipeline, an immediate stoppage of work on the Trans Mountain pipeline expansion and the Site C dam, access without fear to expanded healthcare with people regardless of their migration status, hazard pay and protective equipment, yes, for frontline health workers, but also for grocery store employees, drivers, TransLink employees, and workers in the downtown east side. We also worked with other groups to call on the government to cancel rent, utility, mortgage, and loan payments. Did some organizing around moratorium on evictions and utility shutoffs, and really tried to use the pandemic, but also the global movement last summer and that's still ongoing against police violence to rapidly call for decarceration and a safe supply of drugs. So we really thought it was important to mobilize the people who are relying on this platform behind a set of explicitly political demands. Another thing that I think has been an important takeaway from this experience, for me especially, has been the intergenerational responsibility that we, as mostly young people and students in this group, in this organizing group, felt. In thinking about holding young people accountable, I think that we're by and large falling into the trap of talking about individual people who aren't being responsible. This isn't about drum circles at English Bay or parties on Kitts Beach. I think that what's important is that we realize that we fundamentally systemically failed our elders and seniors on societal levels and not individual ones. In a long-term care system, we've effectively allowed a system to go along letting our elders rot away for years in privatized facilities without proper oversight and without proper conditions. And we've seen the effects of this during this pandemic, especially. Nora Loretto, who's a journalist, has been keeping a database of deaths in long-term care facilities. And as of today, we know that 71.5% of COVID-19 deaths have been linked to senior homes and long-term care facilities, and that's harrowing. And so as a young person myself, who hopefully has decades to go before having to think about senior care, these are obviously not ideal conditions for our elders to live in. And I think this pandemic has, the biggest takeaway for me from this pandemic is that we continue to neglect these conditions. And it's important for us to take this moment to quickly reflect on this. And I think the solution to this extends beyond universal and publicly funded long-term care, but also addresses and explores fundamental changes in how this system operates to ensure that we're exploring humane ways to give elders agency, to ensure that they're cared for and are able to live their last years and hopefully decades with joy. And finally, to COVID-19 coming together and the Social Justice Center at UBC, the pandemic has presented an important opportunity to organize around the homelessness crisis. So last year, it was very clear that other jurisdictions were moving quicker than BC. So California, to some extent, had committed to housing people in hotels, whereas here in BC, we had hotels that were empty with thousands of clean, safe rooms that were available, but our provincial government just wasn't moving. And even today, it's completely unacceptable that our governments are continuing to neglect people who are living on the street, regardless of whether or not there's a pandemic. So we signed on to a letter and did some organizing around ending homelessness. With Derek was also a key figure in this, and it was a coalition of city councillors here in Victoria and Vancouver, as well as activist organizations in both Vancouver and Victoria. But I think that the real takeaway from this was it was important for us to really emphasize the importance of these issues that in mainstream narratives were getting pushed aside because of the pandemic. In summary, I don't want to take up too much of your time, but this year has been deeply informative and has been one that's really made me personally rethink my role as an organizer and as someone who is relatively young to practice the responsibility that I feel, and I think that my generation should feel towards our seniors and our elders. And the real takeaway from this year has been that we have a long way to go to address the injustices and gaps that this pandemic has exposed, and it's been extremely exhausting, but there's hope in collectivizing and organizing. And that's all I have for you today. Thank you for your time.
That's fantastic. Thank you so much, Ishmam. I'm energized just listening to that recap of a small fraction of the work you've been part of doing in this past year. And thinking about the first two presentations, I think as we get to the discussion, we can think about how to scale up some of these little victories we've had. I know Colleen has been very involved in the community health model with the REACH clinic in East Van, and I know she thinks about how to scale that community health approach across the province. The housing, the provincial government was pushed and has taken some positive steps buying hotels and motels in Victoria, downtown Vancouver as well. But yeah, the scale of the problem demands so much more. So you've given us both, the first two presentations, given us a lot to think about. Our last speaker tonight is staying up late with us in Quebec. Thank you, Stephane Bilodeau. It's almost 9 p.m. out there, so we want to really thank you for joining us. You come highly recommended from one of Quebec's most prominent journalists, Andre Noël, who has been doing really essential writing about the pandemic response and the many failures of the Quebec government and the shortcomings of other governments in Canada. So we're really excited to hear your perspective, Stephane, and then we'll turn to Q&A with everybody.
Thank you, Derek, and I fully agree. Andre Noël is really an awesome journalist, investigative journalist, really a great person as well. So, and thank you for the kind introduction you did at the beginning and right now. I just want to add one thing. So COVID Stop is really a Quebec coalition, but just a month ago, we were working with 4 other coalitions around Canada, and we had up to 500 and more signatories of a letter that was sent to all the provincial governments and the federal government, just to make sure they take correctly into account that this is an aerosol based transmission in terms of the virus, and that was neglected in some provinces. Still it is, but I just want to highlight the fact that we're working with our counterparts all around the country, other coalitions and others. And not only that, I was working since last spring, in fact, for the last almost the last year with End Coronavirus. It's an international volunteer coalition as well, with about 5,000 persons all around the world. So caring citizens, community organizers, scientists, surgeon, physician, engineers like me from around the world. So a lot of work is done there as well, including in Canada. Some of this group are from Canada, indeed, such as I am. And one of the things I did there is working on the nursing homes project. So nursing homes, it's the American way of calling the long-term care, essentially, or as we call them in Quebec, CHSLD. So anyway, that's all the same kind of setting. And these are probably amongst the most vulnerable population. And that's definitely one of the reasons. And that's why today I want to talk about, as you rightfully said, Derek, the elimination strategy that we call Zero COVID, COVID Zero, or variation on this this name, but it's the elimination strategy, and I will talk further about that. But I want to start with the reason why we need to go towards this direction and this approach. I would say it's essentially because of the vulnerable population, and Ishmam just mentioned others. So it's this pandemic reveals the inequalities, reveals that some population are really much more affected than others. In Canada, we've seen from the start, and you've seen that in BC definitely, LTCs are definitely, the residents of the LTCs were really impacted from the start in Canada. Not only from the start, but with high numbers. And I'm talking about the start, but just this morning in Quebec, there was a report with a new outbreak in an LTC where all residents were vaccinated. I will repeat it. All residents were vaccinated, and there is an outbreak with 23 new cases. Luckily, or maybe correctly, the cases are mild right now. So this is the first report. That will be explored more. But vaccination is an important thing, but we need to do other things at the same time. And that's the topic I will talk about in a couple of minutes. So LTCs were, in fact, we were studying last summer at ECV, so end coronavirus. We were comparing different jurisdictions all around the world and how they were impacted on the nursing homes, care homes, CHSLD, like in Quebec, or LTC, long-term care, as you're saying that in BC. And we saw significant variation in the impact towards these population in countries. Just for you to know, so in some, so the percentage of persons death that were in fact in long-term care settings, when I will say long-term care, please understand all the synonyms I've just mentioned, because in all countries it's a bit different, but it's all in the same kind of things. Somewhat regulated by government, sometimes it's owned and operated by government, but it's not always regulated. So that's the point here. That's the difference between regular and they are long-term care. So people which have disabilities and needs support and more care than others. So in some countries, 24% of the deaths were in LTC or the like, while in others it was 82%. And in Canada, we were definitely on the higher end of the equation, so really, really high. And we thought it was so, I should not say we, because I followed the data from the beginning, and still in the last few weeks, in BC, in Quebec, in Ontario, the three worst, I would say, in terms of this percentage I was just talking about, the number of deaths in LTC settings. Still, in now these three provinces, it was more than 50% overall. So the accumulation of all the aggregation of all the data is still that level. So 50 in Ontario, it's 49. So they're just reaching this, I would call that threshold. But in Quebec, it's 57, and in BC, it's still 63%. Indeed, the total number of deaths is impacting that. But this is the percentage of people, persons which have been the most impacted in each of these provinces, which are counting the deaths in thousands. I need to repeat. So it's not just 1, 2, 3 persons. We're talking about a huge amount of persons. What was the point with the best countries, essentially. There were different things. So, for example, sharing staff between institutions indeed was affecting more, in fact, was impacting more the countries which were lacking testing, lacking PPEs were affected as well. But one of the biggest thing that was impacting the LTCs was community transmission in the majority, not all, but in a good portion of it. So when it's not really well controlled in communities close by, not necessarily everywhere, but in sectors where there are these vulnerable populations, so the LTC essentially. So this spread from the communities towards the LTC residents. Indeed, the residents themselves are not going from one place to the other, so lockdown and things like that would not affect them directly. But it's the staff, it's the visitors, and it's all the communities which are there and that are impacting these persons. And that's one probably still needs to be validated. We still have an outbreak in a vaccinated setting popping up today in Quebec. So the communities, in fact, surrounding the CHSLD and the staff, a portion of the staff in hospitals, they're more vaccinated, but in LTC, that's different. So all these persons working around, or the families, or the people, are not yet vaccinated. Transmission in communities are still really, really high. So one big reason to control the pandemic correctly and stop the roller coaster yo-yo of back and forth in the upper zone and the lower cases numbers is exactly for that. If we want to protect vulnerable communities, we need to eliminate this virus as much as possible. The countries which are doing the better are those who control the virus. So I'm going to my second topic, which is the very first you highlighted. So the zero COVID. So zero COVID, essentially, it's not necessarily an absolute zero COVID. So we should think of it as a zero uncontrolled case or COVID cases. That's the case which is unknown, which is in the community, which is not controlled by the government or by whatever control, so which is by testing, by tracing, by isolating it or quarantining, whatever. So that's the point. It's a non-controlled case. Every time you have that in the community, you have a risk of an outbreak. And this virus is really tough because it might provoke super spreading events as well. Contrary to other milder infectious disease, this one is very, very infectious. And not only that, it's aerosol based and airborne. So even the micro droplets, which can travel for long distance, not only a couple centimeters or 1 meter, but meters with an S, can infect someone. So that's why it needs to be eliminated as much as possible. So for the first reason, which is, and I have a couple other reasons I will say, so saving lives directly. It's not a surprising reason, but it's something that sometimes has been neglected. So we need to save lives, and amongst the vulnerable population especially. The elimination is also helping controlling transmission in the communities and spare the long COVID impact in communities. You know that even milder symptomatic person can get these symptoms for a long period of time. So even if we're not talking about the most vulnerable population, the milder cases can get what we call the long COVID. So as soon as we multiply the cases in the community, we multiply these long COVID potential patients, which will be putting, and for good reason, putting pressure on the health system on the long term. So it's even if some authorities think of reducing the cost by reducing the measure, on the long term, we actually don't know what will be the cost on the health system because of all the long COVID cases that are in the communities right now. Some of them are already treated because they were identified quickly, others still not. So if we let that continue for a long period of time, that's a second reason. We'll just have these consequences on a new burden on our health system, and then on the economy, because that costs. So that's, I'm talking about cost because that's typically the counter argument against zero COVID or the elimination strategy. Sometimes, and I should say even often, people are saying it costs too much to put more strict measures, and that might be true for some time, but as soon as it's controlled and you control the virus, and that has been done in many countries, I'll talk about that. So then the costs are going quickly on the lower end, the cost of the measures, because you just have a few cases to take care of, no more hundreds and thousands as we've seen in Canada so far. Ishmam talked about that earlier. So elimination is a pro-equity measure. Okay, so if you reduce the cases in the community, and typically this kind of disease and this kind of virus affects, and we've seen that, the numbers are telling us really. So it's the most vulnerable communities which are impacted. So the minorities, so the people which are and with specific and more difficult conditions, these are more impacted. So if we eliminate the virus, that will re-equilibrate the impact of this whole thing. So right now we impact those who should not be more impacted, and we impact them more. So that's why I call that a pro-equity measure. So that's a third reason. So it's helping on inequalities. That's another good point. Up to now, countries that have eliminated COVID-19, eliminated, I repeat it, it's not the absolute zero, it's the zero uncontrolled cases, which are, some of them are well known, like New Zealand, others we're talking less about them, Taiwan, even mainland China is one, but you have others like Vietnam, Cambodia, Laos, Mongolia, Singapore, Australia. And Australia, by the way, at some point in time, especially the state of Victoria, the number of cases per person, so per capita, was more severe, was worse than the UK numbers at the time when they decide to control per capita, not the absolute number. Just want to be clear. Okay, so but that was worse, really. And then they decide to push and to go towards this elimination strategy. Their way, because there are variations on the way to do it, but they decide to do it, and they do it really well. And they started from a situation worse than UK, and you know now who's the worst. Definitely that's UK. Not only that, UK is now, and we all know this, is now generating variants. So we have one which came just before Christmas, but because you multiply the cases in the community, and that leads me to my sixth reason. So when you let the virus spread into the community, you don't eliminate the virus as much as possible. What you allow the virus to do is to replicate, and variants are generated by replication. So if you have just a couple dozen of cases to control, or 100 maybe, the variance is less risky to generate them. But when you're letting thousands of cases generated in the community, then you let as much as possible for the virus. It's an incredible occasion. So he has the capacity to replicate and find the very variant which will be tougher. I'm saying fine, you understand, I'm just putting some image here, but you know the number of replication gives the variant. So if you cut this part of the equation, you cut the capacity to have new variants. That might in turn being an issue for even the vaccine. So that's another sixth reason, which is important as well. So another real good model for that was New Zealand. Nobody has heard and nobody will hear about a variant coming from New Zealand. Absolutely, okay? Because they have controlled that very, very well. At the beginning of the pandemic, in just a couple of weeks, not exactly a couple, 5, 6, 7 weeks overall, they've put the measure in place. They kept on it. They've not loosened it at some point. And they kept on it until it was really resolved. Some are saying, yes, it's an island. Yes, that's all true. But this is an island which has the population of BC, so that's a population of a small country in Europe as well. So plus or minus, I'm just rounding the numbers. But so even if it was an island, it's still a population sufficiently large that with just a couple of cases and the infectiousness of this virus, uncontrolled, could have generated so bad things as well. So that's not a good excuse to say it's easier in Ireland. Anyway, China is not an island, and that they gave really good results on that front as well. So, and there are other countries, I've mentioned many, like Laos, Mongolia, Singapore, and they are close by to big populations, and they have their own big population as well. So that's not a good reason. Another good reason to do that is as soon as you can start to control, and you can do that not necessarily for the whole country. In Canada, you would not start necessarily by doing that by country. Anyway, it's a province owned topic, so health essentially. So, but for Public Health Canada, but the measures essentially, except for the border related measures or buying vaccine, it's coming from the provinces, and essentially the measures which are in fact within the realm of the zero COVID, so testing, tracing, and isolating cases, except at the border, essentially, as I said. So they are provincial related. So you can start with not only the full province, you can start by having green zones in the province. So you do that, and in different regions, essentially in Atlantic Canada, they did really, really well. I was giving examples in the rest of the world, but we had really great examples of Atlantic Canada. There has been some challenge in the last 2 weeks in Newfoundland because of their election and many things around, but typically even that outbreak is still controllable, which is really a really good thing. They're Canadian, as all of us on the call right now, but from provinces that are controlling the virus because they're doing the things that needs to be done. And they have controlled that in a way that they've started to make a bubble. So the provinces in the Atlantic, as soon as they were all controlling their own area, sector, communities, they were able to open their border to other provinces. And it's the same kind of things that can be done in larger provinces. You start by controlling the virus in some areas, and then you control it really well, and then you do the same job in other areas, and then you continue to the next until all the zones are green, okay, as much as possible really. So, and then everything that's popping up, and we've seen that a couple of times in New Zealand, we've seen that in Australia as well, that's more feasible to trace it. When you have hundreds of cases coming up every day, if not thousands, for some provinces, it's almost impossible to do a proper contact tracing because you're no more able to have a sufficient number of person, a staff sufficiently big to call and do a proper contact tracing that all epidemiology school would let you know how to do it. So that's another reason. If elimination or zero COVID allows some of the measures, including contact tracing, to be more efficient. But you need to have started to control your things before. Rapid testing. In Canada, the majority of the province are not using well rapid testing. That's another of the things that needs to be done. It's helpful for communities, and it's helpful at the provincial level as well, because you're no more driving blind in the dark. You know what's coming because you know what it is in the field. So, and contact.
Thank you, Stephane.
Yes.
Just going to ask you to wrap up there on the rapid testing. Thank you for
20
that.
seconds. So rapid testing is essentially the last one I was to talk about. The rest is just controlling. In fact, you need to control, and then you can help and better help, especially the vulnerable populations. And as I said earlier, all the minorities and communities that are more affected. But rapid testing should not be neglected, such as properly isolating cases and, in fact, do a proper contact tracing, which you can do as soon as you start to control the virus and reduce to almost zero. It's just a couple of cases per 100,000. That is some limit that is used essentially, and that's helping to keep on doing things that are not possible right now because of the number of cases. I'm stopping on that. I think you're right. I think it was really too far. Sorry for it. So it was enthusiastic.
No, thank you, Stephane. Thank you. You did a rapid coverage of the global picture and the picture across Canada. Thank you for that, and you've given us a lot more to think about. I'm going to go to questions now and rapidly get in as many of your questions as we can. There is an event coming up on Friday night. I just wanted to highlight, also hosted by the Institute. Really fascinating speaker, Fred Kuwarnu. He is a filmmaker, artist, educator, based in Brooklyn, but of Italian, African background. The event is on Black Italians and digital culture in contemporary Italy. So I'll just pop that in the chat so everyone has that information. So Institute does much more than COVID. So I want to turn to Marjorie's question. Marjorie Cohen has a question for Colleen that we started to get into in the chat, and feel free to jump in the chat if you don't have time to speak to all of these questions. But the question is, do you think Big Pharma was punishing Canada because of the minor threat to rein in drug prices? That essentially the supply has been limited deliberately. So Colleen, I'll let you take it from there.
Sure. Yeah, for the last, I would say 3 years, I've been involved in a big fight around strengthening price controls in Canada. And the response of the industry has been completely unethical and very, very aggressive. They've launched 2 charter challenges, one in Quebec and one in Canada, contesting the authority of the federal government to control drug prices, if you can believe it. They've been to the federal court twice asking for the new regulations to be quashed. They offered $1 billion to the federal government to not implement the new guidelines that are designed to strengthen price controls. They have manipulated patient groups who they fund, and those groups now actually are advocating that higher prices are good for patients. It's just unbelievable. They also have threatened, at least on 2 occasions, to withhold the vaccine if the guidelines are implemented. So I don't know, I can't say for sure whether or not the delay in the supply has been because Canada was threatening to implement the guidelines. But what I do know is this, that they have threatened not to supply the vaccine. And secondly, that the European Union, instead of just sitting on its hands, threatened to sue the industry if they didn't supply the vaccine. So I'm just basically saying it's a possibility. I also just wanted to say that I really agree with Stephane that the vaccine is only one part of what we need to do to wrestle this coronavirus down. And there are lots of other issues that are linked to the vaccine. I'm in support of the vaccine, but I also recognize that we are in a massive, massive clinical trial because they're very poorly tested. We don't know what the outcomes will be or what the effectiveness is. Thank you for the question.
Well, thank you, Colleen. That's great. We have a question here. I think this is from Sven. We should acknowledge Sven Robinson is with us tonight. He is a longtime legislator, one of the great MPs in Canadian history, and a longtime advocate for national pharmacare, among many, many other causes. I think this is his question, if I'm not getting it wrong. So he mentioned that Don Davies, the NDP health critic, has made strong statements in support of public manufacturing of pharmaceuticals. What's your sense of where the federal NDP is at now with the federal convention coming up? So the NDP is having a national convention in April. Do you think this is a policy that they're ready to push more strongly as a party?
Who's the question for?
Oh, I mean, it was for you, Colleen, but others can weigh in as well.
Well, I have to say I'm really impressed with the NDP, the federal NDP on this issue. I think that they have become much more vocal in supporting a public manufacturer than I can ever remember them being in the past. So I'm really happy about that. I don't know what the resolutions are to the federal NDP convention. I hope that it does come up. I think that there is a much greater interest in this issue now, and that the kind of phony drum beating about domestic manufacturing, when we know they're all a bunch of greedy bastards, basically, and I excuse my language, but really that is the characteristic of the pharmaceutical industry. And so I think that there is an appetite amongst Canadians generally, and that would obviously include NDP members, to really, really begin to look at what it is going to take to reestablish public manufacture in Canada.
Great. And maybe this question is maybe more for Stephane, but panelists can jump in on the previous questions as well if you want to add something. So there's a question from Lawrence about the fact that care aids are not currently on the criteria to get the early vaccinations under the BC CDC, nor are they issued N95 respirators, Lawrence says. So you have comment on the situation with care aids in BC. And then a second part to the question, or actually a separate question here, Lawrence is getting two questions, is essentially why have the highest rates, death rates per capita been in the US and the UK in terms of developed countries, or those are two of the highest rates. We mentioned islands for New Zealand, but Britain is an island. Why has their situation been so disastrous? If any of the panelists want to take that, maybe we start with Stephane.
It's absolutely true that it is important, as Lawrence pointed out, and to take care of the caregivers in the long-term care settings, because as I've mentioned earlier, since the transmission is not controlled in communities, they might be, without their knowing themselves, be a transmission vector. So to get N95 respirators for those kinds of persons and to get vaccinated quickly would definitely be an improvement. And not only it is the case in BC that it's not there, but some other provinces also are a bit behind on that front. And that was part of what we did with the 5 coalitions, Canadian coalition that I was talking about earlier. So that was to highlight that there was some lack on that front. Quickly on the other point, so yes, it's absolutely true that many of the biggest or the richest countries, whether they're islands or not, that's not really important. Essentially, it's how they're doing their job. They're managing this virus. This is an epidemic. It's been 100 years since the modern the medical sector is understanding the big principles of an epidemic and how it can become a pandemic. Yes, this virus has a special, some special things, specifics, but definitely the main principles were known from decades, if not more than that. And it looks like the biggest countries and some of the richest have failed on just applying the basic things. And these are good examples that Lawrence just mentioned. As I said, Canada, it was more on the elders and the LTC side. That's the worst portion, I would personally say, of our management of the pandemic. Essentially, first wave was terrible. It's a bit better now, but still there are some mileage to do to improve. And the example of the N95 not required, or vaccination of the caregivers themselves, or the aids, natural aids, that's something that is missing.
Did anyone else want to jump in on that question? Okay, not seeing anyone imminently. I wanted to just read a comment, or part of a comment from Mizanur, who's bringing in the situation of his home country, Bangladesh. That essentially the pharmaceutical industry at the time of independence was completely foreign owned. There was no price control, and costs were 100 times over the manufacturing costs. So there was an effort, part of the freedom and independence and struggle for equality was to bring down the price of medicines. And I guess I just want to take from this comment the issue of global justice, which we haven't talked as much about, you know, and the fact that a lot of the underdeveloped countries are not getting vaccines at all, or they're not able to get the initial vaccines because they've been bought up by countries like Canada. So they're going with Russian vaccines, or I know Cuba is developing a vaccine that they plan to give for free to some countries. Yeah, I guess it would just throw it to all the panelists to talk about the global justice aspect here, and in particular Canada's role. Colleen touched on it a little bit, Canada's efforts siding with the pharmaceutical companies against a country, poorer countries. But if anyone wants to jump on that and elaborate a bit.
I can give it a shot. I think that just as an observer, one of the most striking and egregious parts of my experience has been witnessing this culture of competition earlier during the pandemic. The Canadian government was celebrating itself for its success in ordering vaccines in its diverse vaccine portfolio. And we know that the implications of that are that we're leaving behind countries that are less developed. I also think that Nancy's article is very interesting in the New York Times and points to a larger conversation that we need to have about who's actually getting credit for these vaccines. We hear Pfizer and Moderna getting so much credit for the production of these vaccines when the technology that and the science behind these vaccines have been largely produced and thought out in publicly funded university campuses. Lipid nanoparticle technology, mRNA vaccines, these are ideas and technologies that are only possible because of public funding. We're giving all of this credit to Pfizer and Moderna, who just haven't earned it. So I think a big part of this is to celebrate public innovation and to share this public innovation, because no country, not Canada, not the States, has a monopoly on that.
Can I jump in here?
That's great. Yes, please.
I think that the inequities that we're seeing are so serious, and they're not just because the vaccine is not being supplied to low and middle income countries. It's also that the wealth around the world is poorly distributed. So the way that the vaccine is being distributed, I mean, Africa is completely out of the supply line as far as I can tell. If you look at South America, it's quite uneven depending on which country you're looking at, and also the same is true with Asia. The global South basically is being sidelined in really significant ways, but it isn't just for the vaccine. If we look at the distribution of COVID in Canada and the United States, and not looking at Europe or the UK or other countries, the distribution of COVID is also inequitable, and it is based on the living and working conditions. It's based on racism, it's based on sexism, it's based on all of these other things that increase vulnerability amongst populations. And the distribution of, and that is true globally as well. So what we need to look at is not just the way the vaccine is being distributed. In Canada, we're handicapped at fighting and protecting people. In the city of Vancouver, our community health center is not funded to go out and make sure that people are getting food, that they are not completely isolated, that they are being a part of a community, and so forth and so on. We are funded to provide medical services. And so the focus on fighting COVID has been on medical services and hospital services. But really, if we want to protect people, we have to build in the supports at the community level to make sure that people have the ability to protect themselves and their communities, and not just themselves as individuals, but their communities. That is part of what is missing within our country, and that is also what's missing globally as well.
Lorraine has shared some information about an Urdu language town hall on Saturday. So if anyone on the session here tonight knows Urdu speakers who need information about the COVID-19 vaccines. That's happening on Saturday, so just check the chat. I wanted to come back to you a little bit, Colleen, and maybe bring in Ishmam as well, or really all of you. You've been really involved in the REACH clinic and in advocating community health in general, something that was basically totally shut down under the Liberals and is now finally being rolled out. I know the NDP provincial government has sort of reopened REACH, I believe, and then also there's a new facility in Hastings Sunrise. But you have a larger critique of sort of the allocation of money and resources in the healthcare system. So if you could link the pandemic experience and the lack of a community health approach, and maybe to broaden it out, has the pandemic shown up sort of other things that have only been delivered by volunteers doing mutual aid or by the private sector that could be done by the public sector? I'm thinking here for some reason of like the DoorDash and these, these corporate entities that have profited wildly from people needing these services during the pandemic. Are there other crown corporations, other public entities we could create to deliver those services for the public good that we've realized we need or may need again in the future? That's a big question, but if you want to handle the community health aspect of it at least, and if others can jump in.
Well, I think that for the REACH Community Health Center, we have a membership base. We have very, very deep roots in the community, including the Indigenous community in East Vancouver. And we have seen the impact of COVID, of course, within East Vancouver is very uneven. So I think that the Indigenous community in East Vancouver is about 1.4% of the population, but the representation amongst all COVID cases from Indigenous people is about 5%. It's worse if you go north, where Indigenous people make up about 16% of the population and 37% of COVID cases. So these are very, very vulnerable communities, and they're vulnerable, as Ishmam was pointing out, because they don't have clean water, they don't have decent housing, and they don't have all of these things that people need to be healthy, whether there's COVID or not. And so when the pandemic hit, we had to scramble to mobilize resources to ensure that we were able to provide information in the language that the recipient of the information needed to get it in. We had such a broad array of capacity within the community to survive, basically. And I'm not saying just survive in not getting the vaccine, but survive as human beings who live in an interconnected community. So we were not funded to do that. We still are not funded to do that. And what I would like to see is that this government has learned some lessons about what it takes to actually protect people. It isn't a medical clinic and a hospital only. Those things are important, but you have to be able to make sure that people are connected and relating to each other. I was interested in Ishmam's comments on the mutual aid work that they have been doing in Victoria. Here we tried to do that, and it was very, very clumsy, partly because of the technology. Nobody had even heard of Zoom before, so nobody knew what we were doing. But also because we didn't have the resources to do the work that needed to be done. And that is what the problem is. These are social determinants of health, and that is what keeps us safe from COVID. It isn't just a vaccine, a hospital, or a medical clinic. It is all these other things that we need to protect ourselves. And that is not on the public funding radar screen. We have to rely on foundations and grants and so forth and so on. It's a total mess. I'd be interested to know what it's like in Quebec in that regard. And I'm also very interested in the work that Ishmam was doing. And I've arranged to talk to him later, but I think that the work that he was doing was really, really important. And especially because it's not funded properly to do that work.
Yeah, maybe we can. Oh,
Sorry,
let's
go
go
ahead.
to Ishmael. Well, I'll just take a comment here, and then we'll have time for
Sure, go ahead.
Malcolm. It's a comment that's related to what we're discussing here. Malcolm says the discussion steers us to consider a systemic approach, as has been suggested elsewhere, namely a convergence of various epidemics and global crises that share underlying determinants. Why are we not seeing a public response to tackle these issues as systemic? So why is that analysis still sort of feel like it's still limited to webinars like this?
Yeah.
So take that together with the other things you were going to say, Ishmam and Stephane as well.
Yeah, no, it's definitely frustrating that we're not viewing the situation as one that's systemic, and that all of these injustices are interconnected, and that this isn't just isn't resonating with enough people. But we're trying. So one example I think was when tent cities, or early in the pandemic, when attention was being drawn to tent cities. So in Vancouver, that was the Crab Park tent city near the beginning of the pandemic. Nobody was talking about how COVID would be disproportionately hurting people at the tent cities, how housing was immediately needed to make sure that people who are already vulnerable because they were homeless needed to be saved from these close quarters and congregate settings that they were in at the time. And even during the pandemic, political forces here in Vancouver were calling for the tent city to be cleared. So there's this general sense of really looking for cosmetic solutions over addressing root causes, the reasons why we have homelessness, yes, during a pandemic, but even in the absence of a pandemic. About emergency services, obviously the onus of keeping our communities safe and allowing people to access vital services during a pandemic shouldn't fall on private companies, but it's also important that it doesn't fall on individual mutual aid networks. We didn't have much money. We were quite young and barely 20. Other folks were young too. It's just not a responsible thing to do, to leave this type of work to volunteers. So it's an important opportunity for us to think about building infrastructure to make sure that in emergencies and pandemics that we're allowing people to stay home and stay safe. And that ranges from solutions like paying people to stay home, hazard pay for frontline workers, and yeah, delivery infrastructure for vital services like medications and food. So I think that this is an incredibly important opportunity to really rethink our emergency preparedness.
Ben, did you want to jump in on those themes?
Yes, just a short point. Yes, this pandemic has been revealing things that we should have known before, and many were already knowing them. So vulnerables, as I've repeated, and some minority communities, indigenous communities, were more affected by really underlying conditions, because of these underlying conditions that cause so many of the things. So this is revealing things, but it's definitely the pandemic will not solve anything if the decisions by the authorities, but also some kind of awakening by the population itself that should realize that more help is needed to solve these underlying conditions, as Malcolm said, essentially. So this is one of the things I wanted to mention. Second, to respond to Colleen's point, so in Quebec we have the same issues, and by the way, one of the reasons why I think Quebec was failing at the beginning, we were having the worst numbers of Canada as a whole. So that's because every effort, every resources was put on, I would say, saving the health system. But the health system is essentially the last resort. That's where people which got the disease will go. But first thing to do is to protect the reason why those persons will become ill. So rather than putting every single penny, all your eggs in the same basket, it should have been at least spread a bit more in the communities that would have been it should have been known, would have been at risk a bit more than others. So health should have been spread a bit more than just trying to protect the health system. Anyway, Quebec would become definitely, in the years to come after some assessment of what happened, an example of why not put everything, every dollar, every resources in the same space. Okay, but I want to finish my third comment on that front. So some communities, which should have been at risk, did really well in Canada. So in Quebec, one of the best in terms of the numbers that we face in terms of per capita or whatever numbers you're talking about is the Northern Quebec. And essentially, my brother is working in the Cree Nations. There's 14 communities there. They've done from the beginning the equivalent of a zero COVID approach there. So they're the biggest hub of the Cree Nation there is just I would say a couple miles away, maybe less than an hour driving from the city in Quebec, which is Bilodeau, which had faced a lot of outbreaks. But just the Cree village beside had almost nothing. A couple of outbreaks, but always controlled. So they applied that from the beginning. And same thing in Northwest Territories, same things in Nunavut. So they are on top of the Atlantic bubble I was talking about, the good examples in Canada. And it's not because they are the richest portion of Canada. It's not because they are the most or better equipped portion of Canada in terms of the capacities and resource of their government. It's because they took the good decision and they protected correctly. So I just wanted to close, since we're close to the end, on this. We have good examples in Canada. We just need to reproduce them. There was bad examples, but we should focus on the good one and correct the bad examples.
I think that's a great example to conclude on. We talked at the beginning about not just acknowledging Indigenous land, but talking about the need to restore sovereignty. And that's not in any sense a charitable approach. That will yield better decisions and better empowered communities. And it's true, we saw that in BC as well with Haida Gwaii, telling U.S. sport fishing tourists, like, do not come here, and having to make some of the lodges listen to that. So yeah, the more power we can restore, or the more we can help Indigenous nations restore sovereignty, you're going to see better decisions and better results for those communities. So I like ending on that point. I'll just let Colleen and Ishmam as well say any final words, but we didn't talk tonight about how the COVID pandemic has sort of strengthened and seen new developments of the right and the far right politically, very dangerous developments. But Ishmam's comment made me think about this. The way certain political forces were demonizing the tent cities that had sprung up and really calling for bigger crackdowns. We've made some criticisms of the BC government here today, but the fact is the BC Liberals tried to win that election that happened by demonizing the most marginalized people in our society. They really tried to capitalize on that or create a political backlash, and I would fair to editorialize here that we're very, very fortunate that effort failed. But throughout the world, the far right is a growing concern, and it's merged in with a lot of conspiracist sort of movements around the pandemic. So we are going to add a session, I believe, in April around on that topic near the end of this series. So stay tuned. If you're not already on the Institute's email list, please do sign up. So you can get notices about the rest of this series, Thinking Through the Pandemic, as well as other events the Institute puts on. But I'll just let Colleen and Ishmam have any final words before we sign off here.
Do you want me to go first, Ishmam? Well, just that, this is not the last pandemic, as you said at the very beginning, Derek, or I don't know about the last pandemic, but the last severe virus. The other thing that we also did not talk about was the environment and how the degradation of the environment is increasing our vulnerability to these types of events. And so if we really, really, really want to go upstream and prevent this type of thing from happening, that is one of the things we have to focus on. These are environmentally triggered events, and from my point of view, because of what we know is going on. So that's all I want to say. I also want to say thank you very much, everybody, for attending this evening, and I enjoyed my co-panelists very much. Thank you.
Thank you, Colleen. Thank you, Stephane. Ishmam, we're giving you the last word. And yes, thanks to all the people who attended, and I hope we got to most of the questions in the chat.
Sure. Thank you again for having me. It's been really informative to listen and learn today. Yeah, I think that had we had an egalitarian and fair society, we wouldn't be here today in our homes, isolating. And I think it's an important lesson for us to build a just and humane society, yes, for emergencies, but also for normal periods of time in the future, one that adequately funds our public services, that makes sure that poor and marginalized and working class people are looked after. And a good byproduct of that is that we'll be prepared for a future pandemic. That's all I have. Thanks, Derek.
That is a great vision to end on. So thanks again to the panelists and audience, and stay tuned. A recording of this event will be shared, of the main presentations will be shared later. And we look forward to seeing you next Wednesday at the webinar and throughout the rest of the spring. I look forward to seeing many of you in real life at some point in that nice future as well. So thank you all. Have a good night.